Thank you, Damien. Our next speaker is Dr. Sadri from Geneva, Switzerland. He will talk to us about management of cartilage injury in the hip.
So, good morning to you all. It's pretty difficult to be the speaker after such eloquent speakers as Richard Willer and Damon Griffin, so sorry you're going to have to do with my Swiss accent. I come from Switzerland, from Lausanne. I was a former fellow of Professor Gans, and I was really early in my career confronted with FAI, and this is why I'm interested in cartilage lesions. As you know, FAI does destroy cartilage, and it does so pretty rapidly. So let me share some of my shocking experiences with you. We have talked about conservative treatment. Believe me, I'm the most conservative surgeon that you can see in Switzerland. And as you know, Swiss are not maybe as aggressive on surgical pathology as one would think. This is a case I'd like to share with you. So he's a 22-year-old soccer player in an international club, and he's from Turkish origin. Okay, so and he has bilateral hip pain only when he's playing soccer. So who would treat him conservatively? Hands up. So about half. So hopefully at the end of this talk, you will change your mind, because this was what I thought before. So these are slides from Bern, and you can see it's 1979, and here is axial view, so you can see a clear cam lesion here for those of you that are now getting more and more familiar. You can see the bump over there. You saw it on the AP view as well. So this is 1979. He had to stop soccer playing within 1 year, and this is how he evolved. So we were very conservative. Sadly, 15 years after, you can see that joint destruction, 1994. So my thinking was, okay, this thing progressed within 15 years, and there's a huge spectrum. We have shown that conservative treatment has a role, but I think it needs more time for the joint, to destroy. And case is that he had to stop his professional sport, and this is why he lasted 15 years, but he was taking NSAIDs, and that's how he survived. So he was walking since 5 years with canes, and we told him to wait. This is 20 years after, and you can see that's 1999. And this is how Professor Gans treated him. You can, for those of you who know, that's the Gans ring, and that's how it was treated in Bern. So just for a thought, at 43 years, that's how the outcome was. So that gave me sleepless nights, and here's the talk now. So we do have to always store optimal hip biomechanics if we treat these cartilage lesions, because the killer is the hip biomechanics, and the cartilage is the consequence. So we do treat impingement, we treat dysphagia, we stabilize osteochondral fragments in necrotic hips, hip heads, etc. So I'm not going to talk about that because there's been enough talks on that, but that's the basic point. You do have to treat the biomechanics. So we have two types of cartilage defects, flaps and the real defects. Now, what's the rationale behind it? I used to think that you had to treat the hole, so basically the idea was to get that hole back to normality. Nowadays, we know that this is a difficult thing to do for the time being. And in 2005, I read this article on clinical orthopedics and related research. This is a rabbit model, and they have drilled a 2-millimeter hole in the condyle. And I was shocked to see that you increase the pressure on the adjacent cartilage by 200%. So my thought has changed. We are not trying to fill that hole in. We are trying to save the adjacent cartilage, because if you don't do that, that cartilage gets hammered and hammered and hammered by 200%. So here's a slide to see what the edges look like. That's just after the drilling, and that's after some time of weight bearing. You see how that cartilage bends over. So the idea is to save the adjacent cartilage. So the rationale would be, how do I fill that hole with the best hole filler that I have mechanically to save the adjacent cartilage? Because otherwise, my football player will go on like I've shown you. So if you do have chondral flaps, there are some living chondrocytes in there. Not many, but there are still. And the idea is to keep that chondral flap because it's the best hole filler you have to preserve the adjacent cartilage. So we do subchondral microfracture and fibrin glue if it's necessary. I'll show you that technique. We have to give credit to Richard Willer, who has popularized this technique, and it does make biomechanical sense and also biological sense. So you see a CT with contrast, and you see the flap there, which is nicely diagnosed. You see the chondral labral junction, which is destroyed, and that's the flap that comes. And that's how it looks like. So we would typically keep that flap and microfracture underneath it, like in these images with the microfracture all. So that's the labrum, that's the cartilage flap. The idea being bringing growth factors and stem cells underneath to help healing. And then you would use fibrin glue to stabilize that flap. Always in the idea to save the adjacent cartilage. So these are frequent in CAM impingement. Other colleagues have told you the CAM impingement peels off the cartilage, so it's very, very frequent on the acetabular side. By the way, most chondral lesions are on the acetabular side by majority. You would preserve the flap if it's large and not too frayed, and you use fibrin glue and subchondral microfracture. Now, if it's too frayed and it's unstable, obviously you'd have to debride it and microfracture. And here's a case, too frayed, that case would be debrided and the subchondral bone decalcified and microfractured in the standard way. All our microfracture data is based on the horse model, and it is still used as a model, and it's a pretty good model because the horses that were used in competitions obviously served as a model, and I think it does work in human beings as well. So what about other cartilage defects? Now, this gave me also endless nights without sleep. What is the toxic lesion of a chondral defect? What I mean by that, what is the size of a lesion in the acetabulum where the head of the femur falls inside and the head of the femur gets scraped by the subchondral bone like a rasp? So bear with me a few seconds here. This is a simple calculation for that. I have put the radius of the femoral head to 25 millimeters, so that's an average 50 millimeter head. The cartilage height is 4 millimeters, and that gives you a 3 square centimeter lesion before the femoral head hits the trough and the acetabulum acts as a rasp. So those are what I call toxic lesions, very, very bad lesions. Okay. Now, the second question is, what happens between 0.1 and 3 square centimeters? Again, endless nights without sleep. So that was a more complex question to answer, and we had to go back to the softness of the cartilage. You see the International Cartilage Research Society grades, which are basically outer bridge grades. The more you go down, the softer the cartilage gets, so it's more squashable in general terms. So we had to do finite element analysis here. I brought in an engineer and calculated between 0.1 and 3 square centimeters. Again, a 50 millimeter diameter head, average head, rectangular lesion, cartilage depth to 2 millimeters, and ICRS grade 0 to 2. Again, 2 means a softer cartilage than 0, and pressures between 2,500 newtons to 5,000 newtons. What that means is a 70 kilogram athlete, which is walking, okay, 3 times body weight, and running with change of directions, which we know goes up to 9 times body weight. So this is how it looks like. Basically, we're looking at how the edges of the lesions bend over before the femoral head hits the trough. Interesting. The grades 0 to 2, you can see you have to push pretty far before the femoral head hits the trough. And surprisingly, the weight was very, very important. You see, you need 20,000 newtons, 2,000 kilograms even in grade 2, the softer cartilage part, before the femoral head hits the trough. That's a 200-gram sumo, which is doing contact and contact sports. So weight does play a role. So now the rationale is the following. This is the one that I use and I suggest. Under 2 square centimeters, we do microfracturing. Between 2 to 3 square centimeters, we use an enhanced microfracture, which we call AMIC, autologous matrix-induced chondrogenesis, and I'll show you what that means. The idea being we need microfracture, but because the lesion is larger, we protect that to give the best whole filler we can give. And for the toxic lesions over 3 square centimeters in this population group of athletes, I would suggest matrix autologous chondrocyte transplantation, which gives you the best whole filler in that context, which is very dangerous for these athletes. So what does that mean? I'm going to clarify that. So basically, an AMIC is an enhanced microfracture. For those of you who do not know, you microfracture, you get a superclot, and this superclot contains factors, which we're still studying, in stem cells, and you put a Band-Aid on it. The idea being that the femoral head does not wash away that clot, which is very important for the healing procedure. Now, these matrices come in different types, polymer or collagen. It doesn't matter. The idea is to keep that superclot into place. And that protects it from rubbing against the head, and hopefully that gives you the best whole filler with time. And we know that in animal models that is the case, and there is evidence in human beings, although it does take a long time. It can go up to 2 years to get a good healing of that lesion. Now, ACI, autologous chondrocyte implantation and transplantation, are synonyms. Historically, this was done with the periosteum, and chondrocytes were injected in that. The technique has evolved for arthroscopy, and now we use a matrix autologous chondrocyte implantation, so MACI or MACT, for these toxic lesions. And it's a 2-stage procedure. We have to get the chondrocytes, we send them into the lab. The lab sends us back a matrix which is loaded with an important quantity of chondrocytes, and that is implanted in a second procedure. That is a disadvantage. It needs a 2-stage procedure. The technique is standard. We do not use any complicated portals, so posterolateral, anterolateral, and anterior portals that are used. By the way, that was Dr. Bird's images in his wonderful book, which I recommend reading. And here comes the AMIC technique. So basically, the lesion is triangular, subchondral bone decalcified with a curette, and then microfractures like that. Make sure that the subchondral bone bleeds, and here comes the matrix on top of that. Now, this is another case I'd like to share with you that shocked me as well. He is a 22-year-old professional ice hockey player, which I treated conservatively initially, and here he is 1 year after the conservative treatment because the pain got more and more unbearable. And as you know, ice hockey has also cycles, so sadly we fell at the beginning of the cycle, but these ice hockey players are earning a lot of money, and he decided to finish the 2 seasons, the one where the pain started and the second season. So one year afterwards, he has a 3 square centimeter defect. Every time I show you the acetabulum, so we're looking from behind. I know you come from different backgrounds, so this is the anterior border, that's the femoral head, okay? This is the labrum, this is the transverse ligament, anterior wall, posterior wall, and this is the anterior wall. So I had a French fellow who said, well, nobody will believe you, it's a 3 square centimeter. So he told me, why don't you put a ruler inside? So this is what I did. It's a plastic sterile ruler. Please do not do that. I have never done it again. It took me more time to take it out than do the surgery. But anyway, that's the over 3 square centimeter lesion. And this is how it was treated. So here you have the matrix that is loaded with chondrocytes. And at the same time, we put suture anchors in because you have to treat obviously the FAI component and also the labral lesion component, because in all these cases, the labral chondral junction is destroyed and it has to be sutured back very efficiently to get that seal and lubrication and shock absorbing structure. So here you see the labrum over there, and this is the result. So the 3D matrix, the labral suture again, and obviously the count component was corrected. So here are the results. You see the tonus grades here. What it means is 0 is no space narrowing, and grade 1 means slight space narrowing, and grade 2 means a subchondral cyst. So you can see the grades 2 did not do well. Both of them went to total hip replacement, but the group that had joint space narrowing and classically has been considered as bad cases in the Bernese group with other publications did pretty well. Okay, and you can believe me. Obviously, Damien made the point that every surgeon has this. But this was my experience. I was always told that as soon as you have joint space narrowing, it is not a good case. And these cases do have a lot of chondral damage. So this is my point. In grades 1, it did pretty well. And obviously, in the cases where there were major cartilage damages, even though no joint space narrowing was there, all did well. What about rehabilitation? That's straightforward. I have not reinvented the wheel. It's the same as in other joints. So I do 6 to 8 weeks of touchdown, 5 kilograms partial weight bearing, CPM 1,500 cycles per day at a 1 cycle per second. That's 1 hertz. I usually use a home trainer because it's easier. So I tell them half an hour of home trainer per day. And obviously no twisting or jumping sports for 6 months. So to conclude, please do understand the biomechanics behind it. We do have to fill the defect the best we can. Obviously, the flaps have to be kept because they do contain chondrocytes, and we want to save the adjacent cartilage. Take the patient weight into account. 70 kilograms is not equal to 120, like a weightlifter or a wrestler. The best cases are the tonus grades 0 with no joint space narrowing, but you could use it in grades 1 with minor joint space narrowing. Consider AMIC in the larger lesions over 2 square centimeters and the heavier patients. Consider MACI in the toxic lesions with lesions over 3 square centimeters or the heavier patients. The importance of rehabilitation. We have insisted on this. You have to be patient, and your patient has to be made patient. Although he's a sportsman, it's not going to go faster. This takes several months before they get back to sports. You do have to correct FOI and any biomechanical component. Be careful, these are advanced techniques, they do take time, and as you know, arthroscopic surgery has some problematics with traction times, and the surgeon has to be very, very aware of that because it needs correction of labral lesions, the mechanical lesions like FAI, and also the chondral lesions. Long-term follow-up is needed and will be needed, as Damien stated. I hope I haven't bored you with that, so thank you.